All right. So this is very informal. Feel free to interrupt me whenever you want. I have I get to be the lucky one to talk to you about this amazingly boring topic of fatigue, sleep deprivation, burnout, and depression. But it is important. It's important for several reasons, right? It's important because you're all going to receive a survey from the ACGME tomorrow, which you're going to get asked questions about this. And the last time you probably heard about this was during your orientation, more than a year ago for some of you and 2 years ago. So I know you're not going to remember that you heard about some of this stuff. But it's also important just because as physicians, all of these things are very common in our profession. And we want to be a caring community, and we want to care about each other and care about ourselves. So you're also going to have a resiliency workshop later today. This is one of the kind of mandatory wellness sessions we have you participate in because resiliency is important. All the other activities, they're voluntary, but we all want to make sure we're aware of these things. And I'll tell you how some of these things have interacted our own program in the past. But you can see from the past, when we've answered these questions on our own survey, people reported that they hadn't heard about these things before. And, our survey is important to the success of our program. So that's why I just point this out to you. So try to remember this tomorrow. But, for excessive deep time sleepiness, there's a whole bunch of reasons for this, right? And I know you know a lot of this. Some of it is because of insufficient sleep. Some of it is our natural circadian rhythms. Sometimes we have primary sleep disorders, whether that's narcolepsy, sleep apnea, et cetera. And sometimes it's fragmented sleep. So for any of you that have kids, I'm sure you have extremely fragmented sleep, which is why I only have cats, because they don't wake me up at night, but I'm sure many of your kids wake you up all the time. So you have naturally fragmented sleep. I will say the one thing about our program that is good is we have no 24-hour calls. Long ago are the days where we were up for 36 hours, et cetera, and that might have been good for our kind of learning and following patients, but it definitely wasn't good for our overall health. And it's actually been proven not to be good for patients either, with patient safety issues and that kind of stuff. And, we have ways to go with getting rid of night shifts and stuff. So we haven't done that entirely, but at least we don't have any 24-hour calls in our program. But one of the high risk times of fatigue, obviously it's overnight. It's in the early hours of the day shift. It's when your first night of call or your first night of night float, et cetera, whenever you're doing those transition times or that transition time when you're shifting from the nights to the days and the units. The first 2 to 3 hours of a shift or the end of the shift when we all get a little bit tired. And then early in when your residency, when you haven't had to do overnight calls, because a lot of times students are no longer doing those. There's a bunch of myths related to sleep. Obviously, if you think you only need 5 hours of sleep, you're wrong. Most people need 8 hours of sleep. You actually don't get used to sleeping less. You just build up an ongoing sleep deficit. We've learned more and more about this over time. For many of you that were on the grand rounds yesterday, our speaker was doing a lot of work on sleep in the hospital and in trainees and stuff. So there's a lot more evidence now about what goes on about this. Our previous president said he only needed 4 or 5 hours sleep, but look at his cognitive ability. So I would say you don't want to be like Donald Trump, so don't get too little sleep. You will not adapt, as we already said. Whether you're going to be sleepy and not perform well, as we've proven that that is not true. The more sleepy you get, the more you're unaware of actually how alert you are. I will tell you, for micro sleeps, I do not drive. I'm a true New Yorker. I don't own a car. I never want to drive. But I also know I tend to fall asleep when I drive, so I try not to do it. But I had to do something this weekend where I drove to the Jersey Shore, which is the first time I've done it in years. And actually the cars now, they have all this technology, and it was actually telling me several times that my alertness was, not as it should be, and that I should pull over and take a break. So right there, I clearly was having some micro sleeps that I didn't know about. And obviously I'm not going to drive again because I don't want to kill myself or anyone else. And that just gave me, more ammunition to tell my friends if I have to go anywhere, they have to drive, because they don't want me to put their lives at risk either. But I was actually really surprised because I didn't feel tired or anything like that. And I also couldn't figure out why I kept thinking the steering wheel was loose, and it was actually warning me when I was veering out of my lane and it shakes. So just some scary things to think about when you don't think you're sleepy. So naps, people think that naps don't help. They actually do help, right? But you really want to use naps at appropriate times. You want to be careful of doing too long of naps, etc. But we'll talk about how that can sometimes help you. Coffee can help, but it's very short-term benefit, and you have to use it strategically, right? And then it actually has the problems with it may disrupt your later sleep. You can also become tolerant to it, and as you get older, it has diuretic effects, right? So it's also going to be waking you up as you're trying to sleep as well. So you want to use it kind of expeditiously. So signs of excessive fatigue, these are what we all think of: yawning, nodding off, micro sleeps. You've all seen people do this in lectures where all of a sudden their eyes close for a second, but they actually don't slump over and fall asleep. But then all the other things: decreased cognitive function, irritability, increased errors, etc. I wish I had the loss of appetite, though. I seem to get hungrier when I eat, but chronic sleep deprivation has a lot of actually problems, all right? It causes problems with memory, causes problems with your studying, decreased reaction time, decreases your ability to process information. And again, specifically to residents, you are grossly inaccurate judges of how much you are impaired. That's also something that comes with youth, where you think you're invincible, but you're not, so you just want to be aware of this. But the effects are also, as we already said, increased accidents, et cetera. Luckily, we don't have anyone drive in New York, but it's been shown in the past that being awake for 17 hours is the same as having a 0.05 blood alcohol level content. Being awake for 20 hours is the same as being legally drunk here in New York. So you just want to be aware of this. There's lots of studies in the past that showed there were increased accidents and stuff, again, across the country in places where residents have to drive, so we're not going to belabor that. But there's also been shown that there's an increased risk of exposures with needle sticks, et cetera, when residents are working long hours. And in fact, when we've looked at ours over the last 4 years, we actually showed that most of our needle sticks were happening on the night shifts or in the early morning hours, where people were rushing or weren't as awake as they should have been. Okay, so just recognize the warnings of this: being more irritable, making more mistakes at work, having difficulty focusing, but also feeling like you don't care at work, etc. So what is strategic napping? It's taking shorter naps, right? Because if you start to take longer naps that are more than an hour or two, you start to get sleep inertia, where it takes it longer for you to actually become more awake. So you really want to do short, quick naps. You want to avoid caffeine. You want to avoid exercise. So I know a lot of you go home at night and then you want to exercise at like 9 or 10 o'clock. That's actually not good for your sleep. So you really want to try to do it earlier in the evening or in the morning if you can. Hopefully none of you smoke or do nicotine. And you want to make sure you're optimizing your sleeping quarters, right? You also want to take care of your circadian rhythms, or take note of them, right? So the best times to take naps are actually in the early AM. So if you can get 15 minutes to go take a nap in one of the call rooms in the units or something like that, that's the best time to do it. And then 2 to 5 p.m. So actually when you're working on the night float, it's actually better if you can to do 2 4-hour breaks of sleep. When you first get home, take sleep, get up, do stuff in the middle of the day, then sleep again in the later afternoon before you come in for your night shift. That's actually been shown to be better for you. You want to try to get 7 to 9 hours. I will say I didn't used to do this, and now I'm much better about this. I've just decided I'd turn off all the kind of electronic devices, and I would just tell all of you that is one of the worst inventions in the world. You guys are all on your phones, right, with your head down, clicking until the time you go to bed. That is very horrible for sleep. Besides all the light and stuff that causes problems, it's the problem of just activating your brain and stuff. So it's really much better to do relatively mindless things. Email is also the worst invention in the world, so don't be checking tons of emails and stuff. And we already talked about kind of exercising. Also, when you eat is also important. You don't want to try to eat too many carbs and stuff or heavy meals before going to sleep. I know that's hard for some of you when you're working different shift hours, but you just want to kind of keep all this stuff in mind. And then obviously for those of you with kids and family and stuff, you really want to engage them and try to get some private time where you have that protected time. I understand that's hard, but you got to work with your families to work that out. Obviously, doing all these things with dark shades, etc., is also helpful. You want to really kind of be careful of night or light exposure. which is a problem in the hospital because you're getting the lights all at night. But when you're leaving to go home in the morning, you really want to avoid that bright sunlight in the morning because that's going to reset your clock. So you want to try to wear sunglasses or whatever you can do to avoid that really bright light in the morning and just get home and go to bed. Have nice blackout shades and stuff, etc., because the darker you can make it, the better. And these are all things that can help. They're also doing a lot of work. We had a grand rounds, I guess it was like 3 or 4 months ago, with lighting in the hospital to try and improve all these things. So now we're going to move on to depression, burnout, substance abuse, and just maintaining your emotional and kind of mental well-being. We have intermittent issues with substance abuse and alcohol use in the program every year. You guys are all human beings, right? People use all different kinds of substances. I'm someone that, is not a strong opinion on whether people should use things or not, as long as you're using things intelligently. I just want to point out that even though marijuana is now not illegal in New York, it is still illegal federally. So you cannot use pot or have a positive drug test at any time during your work here, because that would be a reason for you to lose your employment at Mount Sinai. You guys don't get regularly blood or drug tested, but if there was ever a question about impairment and stuff, you could. And so you just want to be careful thinking that, it's okay to use pot because it's legal in New York now, because it's still as not legal for federal purposes, and that would cause a violation of your employment agreement. I'm just going to say that. No one's going to get tested unless we have a reason to know about it, but that's just something that comes up every time. We warn all of our new recruits, because last year someone who came in for the surgery program was not able to start the program, and they actually lost their spot because they had a positive test for marijuana when they were in another state, but it doesn't matter. We have to follow the New York guidelines here and the federal guidelines here, more federal than state. We're trying to get that changed, right? Because again, I'm not someone that believes necessarily like we have to have that rule as long as you're not impaired, but nevertheless, it has not been changed yet. And I think people aren't fully aware of the difference between New York laws and federal laws. So that's all I'll say about that. All right. So burnout and depression, obviously you've heard about this, right? So physicians, in all levels, all specialties, and all clinicians, right? We're having burnout. Even before COVID, it's only gotten worse. During COVID, it can affect you at any stages of your career, including when you're medical students. And these things can lead to emotional exhaustion, detachment, cynicism, low personal achievement, and depersonalization, right? So it can be a whole gamut of things. And you want to just keep an eye on this in yourself and, for your peers. And you've all seen this. This has been proven in medical students. So before they matriculate into school, they have lower burnout scores. And by the time they go through school, they have higher burnout scores. And this only gets worse during residency. This has been studied now for the last 10, 15 years. As soon as you start residency, you start having more burnout. And all these things we've done with ACGME work hours, et cetera, have not significantly improved the amount of burnout in residencies, even though everyone thought this was really going to cause significant improvements. And there's been many studies shows that it increases errors, lower quality of patient care, et cetera. Is it all because of work? No, and everyone likes to blame it all on work, but it's not, right? It has all different aspects that include your personal and professional reasons, the work environment, and the learning environment. As you all know, you all have lives though outside of here. Many of those lives are complicated, and that affects what happens at work. So you just want to always be cognizant of that. I always love the expression that we're all like ducks, right? So we all look like we're nice and calm on the surface, but if you see the ducks' feet underneath, they're going like crazy. So you never really know what's going on in anyone's life that might be affecting them here at work. And I think you've also seen that with like attendings that occasionally are having a bad day or something like that. So you just want to be aware of that and just be aware that all of your life issues are going to affect everything that happens, at work as well. Obviously, that was much worse during COVID when many of you couldn't see your families and stuff. So we're happy that a lot of that is kind of getting a lot better and you've all been able to travel home and stuff. But just being aware of all these things and be aware of these things throughout your life. Doctors are not immune to these types of issues. So why has burnout gotten worse over time for, physicians? Like there's tons of different reasons, right? And for everybody, it's probably different. So there's increased clinical demands, there's decreased autonomy. Like if you've heard any of the older attendings, like where they're railing against the insurance companies and stuff, they feel like they lost a lot of their kind of, autonomy. Longer ago were the days where someone put their shingle out and had a private practice where they ran everything. There's obviously the crunch with decreased time with patients. There's all the reimbursement issues and all the kind of the boxes we have to click because of our crazy US system. There's the problem with the EHR, right? So even though the EHR was a good thing for, kind of making kind of documentation easier and readable and stuff, it's also made a lot more work for all of us. And also it's like zombies that keep coming back, right? So you have things that you try to get out of the EMR, like someone has CHF, even though they don't. And every time you remove it, it somehow comes back. And we haven't really figured out all these problems with the EHR. The good thing is now there's a big push to now really working on improving the EHR to make physicians' lives easier, where before it didn't seem like we had a big kind of input into that. So hopefully we'll be seeing some improvement over that over time. And the other thing too is just kind of this breakdown in kind of the profession of the physician. And we'll talk about that a little bit more later. It affects all specialties though, right? You would think some specialties would have been better, like family medicine or general internal medicine on the burnout scale, but they're actually not. Probably if you wanted to have the least burnout, you should go to preventive or occupational medicine. So you can see this is where most of the GIM specialties are. So they're actually not as bad as just general internal medicine. So for any of you doing primary care, I hope this doesn't disillusion you. But we're actually seeing a little bit of this kind of go back a little bit. So, I think people are really trying to focus now on more work-life balance issues for all types of doctors, including primary care doctors, et cetera. So hopefully this is going to get better over time. Again, there's a whole bunch of reasons why this happens though, right? And these are both personal and professional. But these are the effects that it can have on patient safety. So you can see, here's one study where they were grading kind of patient safety on different units and stuff, and it's by the physicians that were burnt out versus not burned out. And in every place where there were gradings from A down to C with failing grades of patient safety, it was always worse when the physicians were burnt out versus not burnt out. And that's not entirely surprising. Again, there's a whole bunch of reasons why burnout is happening. But the one I want to focus on a little bit here is the rising negative views of doctors. Unfortunately, what's happened over time is, doctors we're not seen as the noble profession we used to be seen as, right? And you can see that in, kind of the way the paternalistic kind of physician was 10 or 20 years ago, where everyone just trusted what the doctor said and the doctor was God. That is not the way we're kind of viewed right now. And that's probably a good thing, but some of that has been somewhat of a loss in kind of our stature in kind of the community, shall we say. I mean, when I first started practicing 25 years ago, there was always the doctor's dining room in every hospital that was very fancy, and only certain people could get into it. And it was a little bit kind of crazy, and that just really has changed. But what I'd like to tell you is, we still are a profession that's different than lots of things that our, friends and families do, right? So no matter what profession you're in medicine, no matter what specialty, you're going to meet people for the first time that tell you things that they haven't told anyone else, right? And that is something very different than a lot of professions. And that's what makes our, specialty still somewhat special, right? Because we're going to help the patients solve that problem. Oftentimes it's not the medical problem that we want to solve, it's other issues that they solve. And that's one of the things that our profession really is different. And I think you should sometimes remember that, right? And I think in COVID, I think even though it was difficult for all of us, I think, we also realized that, our profession is somewhat different, where everyone stepped up to the plate to do the work that we needed to do. I'm not someone that is the big believer in kind of this hero mentality for physicians, because I think this is what we all signed up for. But I think that's also something very special about our calling, that we are here to make, all of humanity better. And I think sometimes you can forget that when you're being so annoyed with nursing tasks and all these other things. So sometimes just step back and, realize that. And hopefully some of you have made relationships in your clinics that, you've formed a bond with patients and they only want to see you, right? And that's something that's very special. They get very attached to you. They trust your judgment. They want to hear what you have to say. And we've all experienced that as attendings in clinics where the resident got switched around and the patient refuses to be seen by anyone but their own resident. And that's something that you should be very, very proud of, because that's a relationship that you've built over time with your patients. And you do that on the inpatient floors as well. For all the interns, you guys aren't interns, but you remember when you were, they wanted to hear from you. They didn't want to hear from this hospitalist that came in for 5 minutes, right? They wanted to hear from you what was going on. And that's something you should be very proud of. And that's a bond that you can build very quickly with patients. These are just all the other issues though why, people get frustrated. I would just tell you that, I've been doing this long enough now that there's always going to be frustrations in your work, right? And you can't get so fixated on some of those frustrations. I think one of the ways to kind of, help yourself over the years with that is volunteer to be part of the solution, because, there's a big difference between seeing a problem, right, and just wanting to rail constantly against the problem, or trying to come up with a solution for the problem. And you've all seen this in different attendings and different residents, where some people want to help the problem and some people just want to constantly complain every day about the issue. And I'm not telling you can't complain. You absolutely can complain. But if we want things to get better, we have to sometimes step up to say, I've noticed this is an issue and I would like to try to be part of the solution to fix it. And then look for partners, in doing that. And that is not for everyone, right? This is the first thing I tell all the chiefs when they're just about to become chiefs, right? One thing you're going to learn out of this job is, do you ever want to do administration or not? Because administration is not for everyone, right? You have all these endless stakeholder meetings and, it seems like one simple problem is taking months to fix. But that is unfortunately the way you affect change in a lot of medicine. So we need people to be willing to, be part of that process. And especially for health staff, you guys know how everything actually works. So I just sent out an email about this blood culture issue that we're going on, because we're finally going to get a timeline on transitioning that to nurses. But I know the plan that nursing comes up with is not going to be ideal. So I'm going to need to reach out to you guys for some of your input to get that moving, because I would like to have this fully transitioned by the time the new house staff come in. So we have 4 months to get what should be a very simple problem taken care of, not so simple, but at least we're moving it forward. All right, enough of that. This is just all the different kinds of work, why people have burnout. Again, there's been tons of surveys about this, but you can see at the top is kind of the computerization, bureaucratic tasks, that kind of stuff. Income is not that much of a big issue anymore. I like to point out to all of you though that, whatever your first job is, even if you're a primary care doctor or a hospitalist, you're probably going to start making $200,000 a year or more, the first day you're out of residency, which is more than 95% of families across the US ever see in their life. So you want to keep in perspective your income. It may not be as high as you want, but it still puts you, in the top 10% of the country. So remember that a little bit. I know it's hard when some of you have hundreds of $1,000s of debt. I feel for you in that. I'm 54 and I literally just paid off my med school debt 3 years ago. So it took me more than 25 years to pay off my med school debt. But it will go away and you'll all have a nice lifestyle. The one place you won't maybe not want to live is New York, because that $200,000 does not nearly go as far in New York as it does 2 hours outside of the city and everywhere else. And my family tells me that all the time. But I just like to point out, keep your income in perspective. All right. So again, many reasons why people don't feel the support. Part of it though is just the way, why physicians don't look for help, right? It's the same reason why other people don't look for help, right? They don't want to look weak, etc. Physicians feel like they should be able to do all of this on their own. Most of us are type A, even if we don't want to, kind of say that we are. Many people, they have what's called the imposter symptom. This is not just something that's seen in women, although it's talked about more in women, it's talked about in everyone. where you don't really feel like you're as good as you really are. And I think I would just tell all of you, you actually are extremely good. That's why you're here in this program. This is why you've all, finished med school, et cetera. And you really want to, know where you are in your expertise level. Now, more expertise comes with time, but you still, have a different level of expertise than other people. I also like to point out sometimes where people kind of want to point out, well, why can't non-teaching do the same as teaching? Well, one of the reasons non-teaching can't do the same as teaching is because you guys, even though you're still residents, you have vastly more experience than our non-physician providers, right? So it is very different to have, a hospitalist and either a PA or an NP versus a hospitalist, resident and 2 interns on the service, because even the intern has significantly more clinical experience than an early in career PA or NP. So you really want to remember that your experience from med school, et cetera, has really led you where you are, and really be respectful of that and understand, you should be more confident in all of your abilities. And hopefully over time in residency, that competency builds. The other reason a lot of times people don't want to report is because we're scared of getting, not licensed. Oh my God, if I see a therapist, is that going to somehow look bad on my career or something like that, or somehow get known back to my employer or something? And all of these things are really confidential. So even if you're seeing a therapist through your insurance, your employer doesn't have access to that information. And sometimes people aren't aware of that. They think, because you work for Sinai or any other employer, that they can go into your own medical records, and they cannot, right? There might be 1 or 2 people in the institution in the finance department that see the overall finances, but they don't see down to your individual level. So you should feel confident in using, any of the kind of, services that are available through your insurance, but we also have services that are available outside through your insurance, which we'll talk about at the end, because we know, despite what I just said, some of you still do not want to access mental health services through your insurance for that fear. So there's some non, kind of insurance services we'll talk about at the end. All right. I'm not going to go through more why doctors aren't happy, because I think, also I think sometimes we focus too much on this. I think the vast majority of doctors are actually very happy with their career, right? And I think, oftentimes we focus too much on the unhappy parts of our career as opposed to the better parts of our career. Part of this is also your own personality, right? If you tend to be more of an optimist or a pessimist. But I think you also just want to remember, the important things about our calling. All right, so daily burnout, we've talked about this already. You can feel mentally fatigued at the end of the day. You feel unappreciated. You feel like you're going through the motions, right? There's too many things to do throughout the day. Your task list is too big. You feel it's repetitive, etc. There's stages of this, right? That's the first stage. The next stage is where you start to become distressed in your life. You start to lose your idealism and enthusiasm for medicine. You feel like you don't have control of your life, etc. You lose the ability to actually look at how effective you're being as well. You can be more irritated in other aspects of your life. I'm sure those of you that have partners and stuff, when you go home sometimes, they point it out to you, like what's going on at work, because you don't seem the same, and you want to just be aware of that. And then we can go on to actually, full depression. And you guys know all of this because you deal with this in all of your patient care, but I think we don't actually think about this in ourselves enough. So we're not going to go through all that, except talk about the lifetime prevalence of depression in physicians is actually greater than in non-MDs. The suicide risk is the same. What's more important though is for major depression in females, it's more common, and the suicide risk is 3 times more common than non-physician females. We have experienced this in our own program that some of you may or may not be aware of, but we had a medical student or a resident in our program commit suicide, a female resident, a year or 2 before I started. And then we had a new attending who was a fellow at Sinai commit suicide my first year here. So this is something that happens. We never know why this happens, right? Everybody wants to immediately blame it on, work. Each of these 2 people had other issues going on in their life. Many of you also might have seen recently that there were several suicides at Lincoln Hospital and several international graduates. And I think it's easy to blame it just on the system and work and stuff, but obviously there's other things that are going on in people. But you want to be aware that we are not immune to this, and that help is out there. Not going to go through that, but there are 400 physicians who commit suicide a year. So again, we want to make sure that you know about the help that is available to you. You want to be looking out for your friends and yourself about burnout. So just be nice to others. I will tell you that over the last 4 years or 5 years, when a resident has been in distress, more often than not, it's come to us from either, the hospitalist on their team that brought it to our attention, or one of their fellow residents that brought it to their attention. It wasn't program leadership that figured it out or anything, because you guys are on the ground with your fellow residents. And that's how we were first brought to the attention that we need to, kind of reach out to this person to help them a little bit. And you may not want to do that because you don't want to get people in trouble or something like that, but you're not getting people in trouble. You're looking out for them in their own kind of well-being. And you can do this in several ways, right? One, you can just do it on your own by talking to them on your own privately and trying to make an assessment of whether you think you need to bring that, to either the chief's attention or my attention. Or if you don't feel comfortable doing that, you can just quietly bring it to one of our attentions or your mentor's attention or something like that. There's many different ways you can do that. And I would just encourage you to do that throughout your career. So let's just talk about burnout is real, right? We have to address that. It got worse over COVID, but it wasn't just during COVID. It was there before. And we have to continue to, work on work-life balance. That's different for everyone. Not everyone wants to do mindfulness. Not everyone wants to do yoga. For me, what, kind of wellness is I don't want to do anyone else's work. So I want everyone to work up to the full ability of their license, including medical assistant staff, et cetera. When I first started at, Mount Sinai, the medical assistants, could only do blood pressures, right? That's all they could do is blood pressures and heart rate. And to me, that wasn't very helpful in an outpatient office, right? So we started to train them to do depression screening, tobacco screening, all the other things that are important. It actually made them get more job satisfaction, but it took some of the responsibilities off of the physicians, and we need to keep doing that in all different areas, including on the hospital side, which is why we're finally going to fix this blood culture issue. But also, hopefully, you're going to see continued changes in the outpatient practice where, you get more support from kind of your colleagues on the team, whether that's behavioral health, the diabetes educators, et cetera. Because all of that helps us, do better patient care, feel like we're working as a team, which helps us with our overall morale, et cetera. All right, substance abuse, we're not going to talk too long about, but it does happen. We've had it happen in the residency program. We've seen a much less use of opiates in the past than we saw before, just because of the controls on opiates. I will tell you, I'm not that old, but when I came to New York and I was at St. Vincent's, we had a practice on 18th Street, and we had a GI doctor that was in the office seeing patients with us, and our staff kept telling us there's something wrong going on, with how the doctor was performing, but none of us worked closely with him, and we never, actually saw what the staff was seeing until one night he didn't come out of his office, and when we went in the room, we found him with a needle in his arm with Demerol because they had easy access to it, because they used it for sedation during EGDs. And so actually all the things the staff were saying were true, right? So we're seeing less of that just because of, less opportunity for that, but we're seeing huge amounts of alcohol use and stuff, especially over the stress of COVID and stuff. And, physicians, we don't like to report these things. We protect our own. But over the course of my time, I've had several residents that were in kind of the, kind of alcohol kind of misuse program through the state. And even for that, where someone is known to have a disorder, they've been reported to the state, and I was assigned to be kind of their mentor for the 4 years. The reporting structure was literally this paper form that they brought to me that I signed that I met with them, and they said they were working on it, and I would send it back to the state. And I had to do that 3 times a year. It was no formal online form or anything like that. So even when someone is reported, we still overly protect physicians because we're afraid of the ability it's going to have on their kind of future career, and I understand that, but we really need to get better about kind of policing ourselves and making sure we're aware when physicians are impaired. I'm not going to go through all this with you because you know what people look like when they're having kind of drug analysis disorders, but I do want to point this out to you. So both the AMA and the ACGME and both of the requirements, physicians have an ethical obligation both to preserve their own personal health and performance. That means both medical and psychological and with substance use, but you also have a duty to report your impaired colleagues. And this is something to remember, right? So if you actually are aware that one of your colleagues is impaired, you have an obligation to report them. Who can you report them to? There's many ways you can do it, right? You can report them, and depending on what role you're in, whether you're a resident or an attending or something, there's both anonymous and non-anonymous ways to report people. But that is your responsibility to do that. And it's the same responsibility on residencies to recognize impairment from illness, fatigue, substance use, et cetera, in their peers and other members of their healthcare team. So if you have noticed that one of your attendings is showing up late all the time, right? You don't have to know why that is, but you need to let us know that's happening, because that's sometimes how we figure out that someone might be an impaired physician. And then we have to do what we need to do as leadership to get that person help. It's never to come from a punitive way. Like, our job is not to get people fired, et cetera. Our job is to get people help because we're a community and make sure that we're also protecting our patients. So you just want to keep this in mind, because I guarantee you over the course of the 40 years that all of you are going to be physicians, and I think it's hard for you to think you're going to be doing this for 40 years, you are going to become aware of this at some point in your healthcare kind of career, whether it's a colleague, whether it's another member of the team, whether it's a nurse or something like that, where you think there might be some sort of impairment, no matter what the impairment is from, and you want to try to get that person help. How can you do that? You can report them to their leader. You can report them to corporate compliance. There's anonymous ways you can report, but there's a lot of different ways you can do it. And just remember, you're doing it to help them out, not to get them into trouble. So what do we have at Sinai to help you? So we have the Wellness Hub mobile app, right, where you can download this onto your phone by going to Sinai Central and signing up for this. This is how I did it. You put your email in, you request the app, whether you have an Android or an Apple, and it gets sent to you and you download it. And in this app, it has a whole bunch of mindfulness kind of and wellness kind of activities, including some structured yoga sessions in it that you can watch videos for. It has some mindfulness sessions in there, some daily reminders and check-ins about how you're doing with your wellness. So this is something that's right for you. You can download that for you, and I'll email this all to you at the end. We also have our peer support network with, if any of you that are involved in RCAs or debriefs, you've heard about this, but these are your peers that are available at both the hospitals. If you want to talk about a difficult patient encounter or something you saw in the hospital, or a patient death or something like that, this is available to you. And then we have the Student in Training Mental Health Program. So this is the one that can be set up through both your insurance and not your insurance. So if you call that support hotline at the bottom, they will have someone who will talk to you right away. And then you have the option of choosing whether you want to go outside of your insurance for a certain number of sessions, or you want to go with your insurance for a certain number of sessions. We usually set people up at different campuses, so you're not going to see someone on the west side because you may interact with that person in a more work-related way. So you usually see someone, if you need to see someone either over on the east side or down at Beth Israel, and their residents come over here for some support. And this is all covered by your insurance, right? You can also get coverage for spouses and stuff as well. And so I'll send this link out to you as well. And then through CIR, which I don't have in the slide set, there's also another way through CIR if you don't want to go through your insurance, where you can get some short time counseling and stuff should you want to talk to people. And we see very limited uptake of this. Unfortunately, even when we send all the information to people, we're talking about a way to set up a one-time meeting with a kind of social worker therapist that you have to opt out of, because those programs have been shown to be a little bit more, show more engagement because people have the appointment and they end up going. We haven't done that yet, but we're in the process of trying to think about that. But if you need help accessing any of these services, you can reach out to me, you can reach out to the chiefs. Again, I'm going to send it all into you in email, so you'll have it, but I know you'll forget about it in a short time. It's also right on the first page of New Innovations if you need to contact any of these people. So we just want to make sure you always feel like there's people you can reach out to. All right. With that said, I just want to open it up to any comments, questions, concerns people have. Issues they've heard about trying to access any of these services. Anybody want to say anything about all this stuff? All right. Then you're free. I'll give you your 20 minutes free before we start. So I give you 10 minutes free from my talk for your wellness. You get 10 minutes of a break, and then we'll see you back at 3 o'clock.